My talk is going to be about a new treatment approach for individuals with a recent suicide attempt that I've been developing and piloting over the past 2 years. That's called Project Life Force, or PLF for short. I'm going to explain the rationale and present some pilot data, probably very quickly. But the backstory begins with a 5-year randomized clinical trial that I ran, 6 months of DBT versus enhanced treatment as usual in high-risk suicidal veterans that I published last year. About 50% of those individuals had borderline personality disorder. And I found no significant differences between the two treatment arms in all of the primary outcome measures. Everybody improved, but the DBT arm people used significantly more clinical resources. So as a result, the DBT providers in the VA are nationwide are now furious with me because we didn't find significant merits to DBT, but it did propel me to find a way to find more effectively use of the DBT emotion regulation skills in the service of suicide prevention. So hence, this is Project Life Force. You all know that suicide is, for veterans, is in the news. 20 veterans kill themselves every day. Most recent suicide report that came out this summer, which is the most comprehensive to date, that veterans account for 18% of all suicide deaths in the U.S., and that 65% are over the age of 50. Particular high-risk groups include women and men in the lower age ranges, 18 to 29. I just quickly want to show you that the blue line are the 18 to 29-year-old veterans, and that the suicide rates are increasing for veterans and males as well as females over civilians. Okay, so here comes the new treatment approach. Suicide safety planning, and I'm sorry Barbara's not here because this is something that she has really been the force behind. And at least in our hospital, I think in others as well, in the VA system, it's mandated for all patients who are high risk. And basically the safety plan helps people recognize their warning signs, use internal coping strategies, and identify what those are. Labels social context that you can use for support, what family members can you contact, and it provides information in case there's an emergency and basically how to keep the environment safe. This is probably very familiar to most people. The safety plan actually started as a 10-session, one of the sessions of Greg Brown's 10-session CBT treatment. It's a standalone intervention, and it's considered a best practice by the Suicide Prevention Resource Center. And as I mentioned, it's mandated on all high-risk patients in the VA. We did a qualitative study of veterans who used the safety plan, where we interviewed them upon the use of the safety plan and then 1 month later to try to understand. And our sense was it was very dependent upon how well the safety plan was actually filled out. But what we did find is that people used their safety plan anywhere from not at all to several times a day, that it was important to have the clinical person who helped you design it to be involved in the care. But there was problems including lack of a social network, feeling too withdrawn and depressed to use the safety plan. The burden was too great to carry out the plan alone, and that actually if you could share the plan with somebody else, it was more helpful, and that if there was some way to not lose the piece of paper, because most people would say, oh yeah, that thing I got upon discharge from the hospital, I'm not sure where it actually is. So this new treatment approach tries to maximize the use of the safety plan and identify some of these gaps that we identified with this study with this new program. And basically what PLF does is it teaches distress tolerance and emotion regulation skills, but it's applied to the individual steps of the safety plan. It introduces the use of a mobile safety plan app on your phone, and it helps veterans, suicidal veterans, identify individuals that they can ask for help, and we actually role play practicing asking for help. A lot of our veteran males have a very, very hard time admitting that they need anything from anybody. And also the main goal here is that we want to develop detailed, personalized, and meaningful safety plans. Okay, so that's actually what the program does. Okay, so it's a 10-session group, and basically, go the wrong way here. It's okay, we'll just do it this way. So basically, each step of the safety plan has a corresponding emotion regulation skill or DBT skill that corresponds to it. So the session 1 is about psychoeducation, about suicide, and then the step number 5, which is the crisis numbers, and they meet the local suicide prevention coordinator. And the skill that's covered is crisis management skills and urge restriction. Identification of warning signs, which is the second step of the safety plan, corresponds to emotion, thought, or behavior recognition skills. The second step of the safety plan, or session 3, is internal coping strategies. We actually teach patients self-soothing and distraction skills. The third step of the safety plan, or the 4th session, identifying people to help distract. We actually discovered that many of our veterans had nobody that they could actually contact. We actually teach them how to make friends. How do you make introductions? I'm not sure that'll be a friend that they can call, but just at least to sort of address this deficit. The next step of sharing the safety plan with family, this turns out to be a very loaded problem, so much so that we've actually now have a second grant to involve family members in safety planning, because this step, often the family member didn't even know that the safety plan exists, and the veteran himself or herself had a very hard time telling the family member about the plan. And so we actually role play how to do that and do a pros and cons of whether they should be identified. This next step, professional contacts. How do you maximize your treatment? We talk about problems that might be going on with the clinical team. Are you being honest? I actually had a patient in the group that I've been working with for about 12 years who, unbeknownst to me, was carrying a package of pills with her at all times, and that was her plan, but she never told me about it, even though we actively met individually for many, many, many years. That came out in the group very quickly. The next step, making the environment safe. We have a whole psychoeducation lecture about means restriction. Gun safety happens to be very, very important for our veterans. Many of them actually have guns and have access to guns and use guns. To actually talk about it in an education way, it turned out to be very, very valuable. We added a session, improving access. You actually can download safety plan apps, and we actually spend a session, we picked the virtual Hope Box. We actually download the app on people's phones and play with it for the hour and put the safety plan into their phones, and then ask them to use it and come back the next week and report on it. We have a couple additional sessions, health management, where we talk about eating well, getting enough sleep, and then a 9th session where we try to build positive emotion and have some kind of meaning to life, although we're trying to probably redo that session. And then a 10th session where the patients actually share their safety plans with each other and review the progress that they've made. Okay, and this is what the actual virtual Hope Box mobile app looks like. I highly recommend it to people if you haven't seen this. It actually has meditations on there, coping skills, and little toys that you can actually, like little Sudokus that you can do, and patients have really enjoyed that. Okay, so the thing that I thought this was a great idea. What I really want to leave people with is this idea of the importance of a group, and it's really what you were talking about, Paula. This is one of the only manualized outpatient group treatments for suicidal individuals. Now, yours isn't manualized. It sort of comes up with whatever the material is. The nice thing here is that every session has a protocol that we follow. There's enough ability to kind of go with the flow of what patients might be coming in, but there is a structure to each session. Now, we know that groups can diminish social isolation, increase social support, a protective factor against suicide. I won't actually go over this because I think Paula did such a nice job. But I want to say that when I went to the literature, I was actually surprised to learn how little information there is on group treatments for suicide. And if you think about DBT, how many DBT therapists do we have in this room? Quite a few. It's actually, you're not supposed to talk about suicide. It's actually... that is, if that comes up, then the topic is changed. There is one session safety planning inpatient group where I think they do this as an inpatient in a group setting, and there is another psychodynamic, non-structured, not manualized group that is done for suicide prevention, and that is it. There is no other literature, and this is the only one that's manualized at the moment. Okay, so I have a pilot grant from the VA to look at feasibility and tolerability of this intervention on 50 veterans. We have some outcome measures. I won't go over the feasibility ratings or the clinical assessments. What I want to actually talk about is a little bit of the pilot data. We've run now, so it's 10 sessions and it runs continuously. So the nice thing about this is that when a patient comes off an inpatient unit, they don't have to wait till the session 1 starts up again. They can come in at any point. So if you enter at session 5, you go 5, 6, 7, 8, 9, 10, and then you pick up 1, 2, 3, 4, 5. So it just keeps cycling, and patients can enter at any point and stay for their 10 weeks. We've had the experience that when people are feeling a little uncertain, they can come back in at any point. So we've actually had some people come and do 2 cycles or just come in when they're not feeling well at all. And the nice thing is that for our high-risk patients at the VA, they're mandated to be seen for certain kind of monitoring if they're on the high-risk list. Having this weekly treatment actually meets that mandate. So the clinicians are very, very excited, and we work closely with those clinicians. We want them to take their safety plans once they're developed and have their clinicians sign off on it so that it's actually part of the treatment. Basically, I want to say is that this is not quite up to date, about 75% of the patients have completed over 7.5 of the 10 sessions, which was one of our feasibility outcomes. What I actually want to go back to is some of the qualitative feedback, because I think that's where it's most helpful. We asked patients, how did they use the safety plan more effectively? I learned about the crisis line and used the text feature. The Virtual Hope Box app was a favorite. Going through each step in depth made it feel like a living document instead of just filling it out on the fly and never using it. Knowing warning signs when a bad feeling was coming and knowing which distractions are available to get me through was huge. I put the safety plan on my phone. I actually called people on my plan. So there's a way in which the plan actually starts to become active. It actually helped depressive and suicidal feelings. Hanging up my safety plan and making it visible was reinforced in PLF. Seeing it daily is a positive reminder there's help out there. PLF had the most profound effects on my will to live, the most in the past 4 years. I now have a reason to get out of bed in the morning, and it can last through the week until the next PLF meeting. And one of the things that happened, which I did not anticipate, and I'm very interested to see if this would happen in civilians, is that many of the patients, because this was a group, sort of a group unit mentality developed. So we would have patients coming not so much for themselves, but they wanted to make sure that their comrades or their brothers were going to be okay. And so basically, if you think about what veterans had to do is life and death, here we are mimicking that again in a life and death situation in a group, in their unit, and it turned out to be very, very powerful. It's the first time that I was ever done a study where clinicians stopped me in the hall and said, I don't know what's going on in that group, it's really helpful. One of the co-therapists said to me it was the most powerful clinical experience she's ever had in her entire training. And actually patients who weren't in my group and other groups said, you're saving my life. So I've been doing a lot of clinical studies in my career. This is the first time I've actually gotten that kind of informal feedback from participants. And I just want to say this idea of increased connection and sense of belongingness and lessened loneliness really echoes what you were saying, Paula. I got to listen to the stories of my brothers. It opened up sympathy and empathy in my heart because I could relate so much. I thought I was a misfit, even though you hear about people struggling with suicide. To actually connect with my brothers in this fight was powerful. It's another battle we are facing. And I think that just captures the essence of what this program is about. I came out, some of my family members came out as having these struggles as a result of talking with group members. And then this is just my one data slide to show that suicidal ideation scores did come down as in our first cohort. I have a video, I'm sorry, audio, but I'm going to skip that. It really just, it's a patient basically saying that for him, when he put the gun in his mouth, to meet another patient who had put a loaded gun in his mouth was really, really powerful. And he said that the next veteran who comes in and wants to put a loaded gun in his mouth, that he's going to tell them not to do that. So basically my hope today was to really reinforce this idea of the power of group. It is not stigmatizing to talk about suicide. There isn't contagion, which I think is one of what people were worried about in the field. It actually is quite relieving for these patients. I hope to come back in a few years with a randomized clinical trial of this intervention. And I'll stop there.